All right. Good morning, everybody, and welcome to Pediatric Grand Rounds. We are back virtual today and for the next couple of weeks due to a plumbing issue in Wright Auditorium, but we will keep you posted as to when we will be back live. And we're always on WebEx. Now I have the pleasure of introducing Dr. Kristen Meyer, who is an assistant professor at the University of Washington and a clinician scholar in the Division of Pediatric Hematology and Oncology. She did her pediatric residency here at Seattle Children's, completed her Hem-Onc fellowship at Children's Hospital Colorado, and then did an additional year of fellowship in hemostasis and thrombosis at the University of Michigan. She's the director of the Hemophilia Treatment Center and the Adolescent Bleeding and Clotting Clinic here at Seattle Children's Hospital and has a particular interest in comprehensive care for adolescents with heavy menstrual bleeding and hormone-related thrombosis. Dr. Meyer, we're so glad you're here, and you can take it away. Thanks, everybody.
And thank you for having me on today to talk about this topic. So first, my disclosure slides. I have no relevant conflicts of interest to disclose, and I will not be talking about any commercial products or services. And then before I start, I think language is really important, and so I want to have a disclaimer about language first. To simplify the discussion in my talk, I will use the word female to refer to individuals with an XX karyotype. And in reference to the capacity to menstruate. I'm doing this for many reasons, but in particular because I'm going to be discussing X-linked genetic disorders. I acknowledge that this term is exclusive. Individuals may identify as female with different karyotypes, and these experiences I'm describing may also apply to all people with the anatomy that allows for menstruation, who also can have different karyotypes. The objectives for my talk, which were shown before, include to understand how period stigma and sexism have negatively affected our ability to recognize bleeding disorders in females, using hemophilia as an example. Hemophilia is not the most common bleeding disorder that we see in females, but it has some unique challenges, and so I want to talk about it separately today. My second objective is to evaluate females for bleeding symptoms and iron deficiency. And thirdly, to describe trends in care for females with bleeding disorders. Before I get started, I wanted to put up a clinical case to illustrate some of the issues that we're going to talk about today. This is a 14-year-old who presents with fatigue and more trouble keeping up with her teammates at soccer. She reached menarche at age 12 and says her periods are not heavy. Her older brother has hemophilia A, but no one else in the family has been diagnosed, and mom was told during pregnancy that she is not a carrier. Of course, because this is her first time coming in since reaching menarche, she gets blood work to check for anemia, and her hemoglobin is 11.2, which is a little on the low side, and the ferritin is 6, which actually doesn't flag as low because in the computer system, the reference range is 6, the lower limit is 6. And so this doesn't even appear abnormal in the computer. So I'm going to come back to this case towards the end of my talk. First, I'm going to try and give a little bit of introduction on hemophilia for those who don't think about hemophilia all the time. Hemophilia is a rare X-linked bleeding disorder. There are two types, hemophilia A and hemophilia B. Hemophilia A is due to low factor VIII activity, and hemophilia B due to a low factor IX activity. These are due to variants in the factor gene, and about 99% of the time, we can find a causative variant. Historically, the types of bleeding symptoms followed in research studies and clinical practice are defined by the male experience. And if you look up hemophilia in a textbook, you will probably see a picture like this. And this is, in fact, a picture from Williams' hematology textbook, which shows the joint disease that is caused by bleeding into joints in patients with hemophilia. And historically, this is one of the main symptoms described because it is very painful and debilitating, was first described in the 2nd century. And the term hemophilia was first used to describe this condition in the 1800s. The first description of how hemophilia is inherited is in about 1820 and describes it as a condition transmitted entirely from unaffected females to their sons. And until freeze-dried plasma-derived factor concentrates became available in the 1970s, this was a common experience among males with hemophilia and very painful and debilitating. Fortunately, now we have a lot of great therapies to prevent bleeding in hemophilia that have changed the course of joint disease significantly in these patients who have access to those medications. We use the terminology mild, moderate, and severe when we describe hemophilia to describe the baseline factor level for the patient. And so mild describes someone who has a factor level between 5% and 40%, or some people say up to 50%. Moderate is factor levels between 1 and 5%, and severe for factor levels less than 1%. This is really helpful when you're describing a clinical scenario, but we know that bleeding symptoms don't correlate perfectly with factor level, although it gives us a pretty good idea what to expect. And then the term hemophilia carrier is used to describe someone with more than one X chromosome and who has one hemophilia causing gene variant. So the term carrier, which is still the term that we use to describe this phenomenon, implies that females are asymptomatic, but we know, in fact, that 1 in 4 carriers are symptomatic with bleeding. And the way we think about that, at least in research, is using bleeding assessment tools, and the most commonly used one is the ISTH BAT score. So 1 in 4 carriers, so females with one gene variant, will have a high bleeding score. Historically, females with hemophilia who are hemophilia carriers were not described as having hemophilia, but in 2018, the ISTH, the International Society for Thrombosis and Hemostasis, did change the terminology, saying that females should be described as having hemophilia if their factor level is low. And that's still not something that is done universally or consistently. When we're thinking about the inheritance of hemophilia, it's really important, of course, that it's X-linked, but that we don't describe it as recessive, although that is done in a lot of literature, including things that you might read in the current literature. And that's because recessive implies that carriers aren't symptomatic. And so here is a picture showing how we think now about hemophilia inheritance. So if you look on the left-hand side, it shows children who are born to a male parent with a hemophilia mutation and a female parent who does not carry a hemophilia mutation. And in this case, 100% of females who are born will have a single affected X chromosome. So these are children who may or may not develop hemophilia symptoms and can pass it on to their children. We call these obligate carriers. So females born to a father with hemophilia are obligate carriers for hemophilia. And all males born will not carry a hemophilia mutation. The most accurate way to determine if a female is a carrier is genetic testing. Although a low factor level might give you a clue, that's the best way to test is truly to get genetic testing. Rarely can have severe hemophilia. This is very rare and can be due to it can come about a couple of different ways. One of them is for them to be homozygotes or compound heterozygotes for a hemophilia variant, but this is very rare. It can also happen if there is very extremely skewed X inactivation, such that only one of the X chromosomes is expressed in the body. X chromosome inactivation is also referred to as lionization because it was described first in the 1960s by Mary Lyon. And if you want to talk about sexism, her story is really interesting. She was a brilliant geneticist who got her degree in the 1940s and at a time when she couldn't actually get a real degree, and then went on to discover this phenomenon and wasn't actually taken seriously or elected to the Royal Society for 12 years after her discovery. Commonly, females with hemophilia are heterozygotes who have mild hemophilia due to more mild skewed X inactivation. This is not rare, and we know that a significant portion of hemophilia carriers have factor levels that are truly below the normal range. And so on the right here, you can see a graph that shows clotting factor activities in carriers and non-carriers, and the mean factor activity level is around 60% in carriers, but 100% in non-carriers. And what's even more interesting is that carriers can have bleeding despite having baseline factor levels that are in the normal range. And I say quote unquote normal range here because normal ranges can be a little trickier to use in females, particularly if they're pregnant, because we know that factor levels, particularly factor VIII activity levels, go up during pregnancy. So here is an excerpt from the first described case of a female with hemophilia, which is in 1923. And this article describes her bleeding history, and I'm going to actually read it out because I think it's very remarkable. So it says, at the age of 10 years, she was found unconscious from bleeding following tooth extraction performed a few hours previously, and she was in the hospital for about 3 weeks. On a subsequent occasion, she suffered from severe hemorrhage from a cut of the thumb, for which she was treated in hospital. And at the age of 21, an abscess in the labiogingival fold was opened. Severe hemorrhage followed in spite of plugging, and she was in bed for 2 weeks. She always had a great tendency to bruising, but only after definite injury. And at the birth of her son, she suffered from postpartum hemorrhage. So you don't have to have any medical experience to hear this bleeding history and think that it's pretty striking and horrifying, in fact. And despite this description in the paper, their conclusion towards the end was that there must be 3 different ways that females can have bleeding. 1 is they might have well-marked hemophilia resembling that in the male. 2, they could have a hemorrhagic diathesis in females not connected with hemophilic families. Or 3, they might have an abnormal tendency to bleed that is slight or atypical as compared with well-marked hemophilia. And they conclude that this patient appears to belong to this last class. It's striking that they describe this bleeding history as slight. I don't think any of us would truly do that today. And I have no explanation for this other than an implicit bias that women cannot have bleeding from hemophilia, or that their bleeding is somehow normal or physiologic. There were not very many females with hemophilia described after that, but there were a couple in the next 20 to 25 years. And in 1951, there were at least 3 that had been described. And this is an article describing hemophilia in women a little bit more generally. And it says, hemophilia is a recessive sex-linked characteristic transmitted by silent female carriers to their sons. And they go on to say that there are many people who believe that having both X chromosomes affected would in fact be fatal, and so this is impossible. And then, based on the described 3 different described cases, they make the conclusion that the amount of menstrual bleeding cannot depend on blood clotting and must be a separate phenomenon. And of course, we know that heavy menstrual bleeding can be due to many different factors, but for sure can be due to disorders of blood clotting, and it's a very common symptom in our patients. So this basically discounts the main bleeding symptom that we see in females as possibly being related to a bleeding disorder. Are papers shortly following this that dispute this a little bit and question it, because they were able to do some pretty good coagulation assays by now. And this is a paper that compares coagulation assays in obligate carriers, so known carriers of hemophilia, to normal subjects. And the headline for their paper even says, evidence for modifying the classical sex-linked recessive hypothesis. And if you look at this table in the top right, it says that obligate carriers have a 15% risk of having factor activity levels that are in fact below the normal range, whereas this is only 2.5% for normal subjects. And so more of them have abnormal coagulation. And this paper also talks about how more of them, interestingly, also report bleeding symptoms. And this was right before X inactivation had really been described as a phenomenon. And this paper is really interesting and has many interesting hypotheses for how this could be, including a multiple allele hypothesis. So they're trying to twist around what was understood at the time about genetics to understand why it could be that females could have low factor levels. But the exact same authors published a paper a couple of years after this, sort of backing out of this suggestion, saying instead, occasionally a history of mild bleeding is elicited, but this is not unlike that described by many normal women. So again, saying that females who have bleeding, even if their factor levels are low, that this is physiologic and not a real phenomenon. Fortunately, this language has not gone away and can be seen in more recent papers. This is a really interesting paper from 2021 describing diagnosis of bleeding disorders in males and females in autosomal inherited bleeding disorders. So these are not X-linked bleeding disorders, and we don't even have this barrier where there's an understanding that somehow the genetics makes it impossible for females to have bleeding. And this paper compared, included patients with autosomal bleeding disorders, which includes von Willebrand disease, rare factor deficiencies like factor 11 deficiency, and congenital platelet disorders, and compared things like the age at which patients reported their first bleeding symptoms, how severe their bleeding symptoms were, and what was the diagnostic delay. So what was the time that passed between their first bleeding symptom and when they received a diagnosis? And the main result from this paper is that the diagnostic delay in men is significantly shorter than it is in women. So on average, the diagnostic delay was 6 years longer in women compared to men in this study. Half of all men were diagnosed with their bleeding disorder within 2 years, but half of all women only within 14 years. And so they have some interesting conclusions about why they think this might be. But one of the sentences I think is most important is here, which is that men may present more often with spontaneous or traumatic bleeding at a younger age. And since these bleeding are not physiologic, they may be investigated early to diagnose or to rule out an underlying bleeding disorder. So I guess this is suggesting that somehow very small male children are more likely to get hurt or to have bruising or to bleed than female children. But female children just have bleeding that is physiologic. Again, this perpetuates this myth that female children or females in general have more physiologic bleeding than males. Just to give them a little bit of credit, there is a very long part after this in the conclusion that promotes the cause of trying to diagnose women with their bleeding disorders earlier and all the benefits that would come from this. But it is interesting, this made it past the reviewers and they were able to publish this sentence, which implies that women have more physiologic bleeding at a younger age. It's also interesting that this delay exists regardless of whether the disorder is X-linked or not. And it is something that in the bleeding disorder community, we're trying to improve. So in females, particularly in hemophilia, bleeding symptoms are often minimized, and laboratory reference intervals and misconceptions about how to determine carrier status perpetuate inequities in care. So we talked a little bit about the reference intervals that are used for factor activity, which can be less accurate in conditions like pregnancy. And then I'm going to talk a little bit more about how reference intervals also affect our ability to diagnose iron deficiency. There is a persistent belief that females cannot have bleeding symptoms, and this leads to delays in referral and diagnosis, and also has a negative psychological impact on patients who are living with the disorder. And there are papers that ask with structured interviews asking patients about quality of life and psychological impact of being a carrier, and a lot of the statements they make and the quality of life issues have really not changed in the last 20 years. So we can't talk about minimizing bleeding in females without talking about period stigma, and of course someone could give an entire talk on period stigma, but menstrual periods have been stigmatized for centuries and are very rarely depicted in popular media. There are some religions and cultures where women are separated from society during menstruation, and in popular media, like in the movies, a lot of the time the main character who's having their period is also separating themselves. So I tried to think, and I might be showing my age here, but about what movies I could think of that I would have watched or could have watched as a young person, as an adolescent, that would have depicted menstrual periods. And these are the three that I have seen that I could come up with. I think there are some others more recently that I haven't seen yet. But in my girl, Beta Sultanfuss has her first period, declares that she's hemorrhaging, is completely unaware that this is going to happen, of course. And then when Thomas J comes to the door, she tells him to go away, actually pushes him over on the front step and says he has to come back in 5 to 7 days. In the more recent movie, Are You There, God? It's Me, Margaret. Margaret also has her first period, but thankfully, and this is a much more recent movie, she is prepared, and actually it's a joyous occasion. So I think things are improving. She's very happy to get her period and has some idea what to expect. But in neither of those two movies is there any menstrual blood actually shown. The one I've seen where menstrual blood is shown is in Superbad. I don't know if anyone has seen that scene in this movie where Seth gets menstrual blood on his pants after dancing with a girl. And it's mostly used as a gross out moment. Again, it's establishing shame around periods. So we know that adolescents aren't going to learn about their periods from the movies. And usually they learn about menstruation from their mothers. This is a real issue in families with bleeding disorders, because abnormal bleeding can be normalized in families because mom says your periods are just like mine. That's normal, when in fact both of them may have a bleeding disorder. There are studies showing that less than 10% of pediatricians and family medicine physicians document a full menstrual history at well adolescent visits. And there are a lot of things to do at well adolescent visits, but this is a sort of, for an adolescent female, can be thought of sort of as a vital sign to understand how they're doing and what if they might be at risk for various disorders. But it's something that we are not very good at doing. So what is heavy menstrual bleeding? The cited clinical definition for heavy menstrual bleeding is usually menstrual blood loss greater than 80 milliliters per cycle. This is an interesting definition that came about from a study in 1966 where they did quantitatively measure menstrual blood loss. And then they also took the sort of drew a line where the women had negative iron balance, were found to have negative iron balance. So I think that's an important way to define this, but also really depends on their dietary intake of iron. So I'm not sure it applies to all populations. Also, this while it's interesting and maybe helpful in research, it's not something that's really helpful in clinical practice because it's very hard to quantitatively measure menstrual blood loss at home, and it's not something we can ask our patients. So the more recent definition of heavy menstrual bleeding that we tend to use the most it's the accepted definition by the American College of Gynecologists, of Obstetricians and Gynecologists, is excessive menstrual blood loss, which interferes with a woman's physical, social, emotional, and/or material quality of life. And when we are taking a history from a patient, we often use these period red flags, or otherwise known as the 7-2-1 rule, which is periods that last longer than 7 days, are closer together than every 21 days, needing to change a pad or tampon more often than every 2 hours, or passing clots larger than 1 inch. And having one or more of these in the history could be concerning for heavy menstrual bleeding. Of course, this isn't perfect either, especially now where many adolescents are using period underwear or menstrual cups, where this definition doesn't even mention those. But it can be a really helpful tool for trying to get a sense of whether the menstrual bleeding is heavy. Heavy menstrual bleeding is the most common symptom in females with a bleeding disorder. It occurs in about 90% of females with von Willebrand disease, 87% of females with congenital platelet disorders, and 10 to 82% of hemophilia carriers. And this large range next to hemophilia carriers tells us something about how well we understand who is a carrier and who is not, and how good we are at asking them about menstrual bleeding, because I think honestly we just don't know. 15 to 30% of adolescents with heavy menstrual bleeding have an undiagnosed bleeding disorder, but there are recent studies showing that only 1 to 2% of those get screening labs to look for a bleeding disorder. So we're not very good at checking. There are some really great self-administered BATs, or bleeding assessment tools, that are available online, where an adolescent, maybe depending on their age, maybe depending on their age with the help of their parents, can fill out a questionnaire about their menstrual periods and other bleeding symptoms they may have to try and help determine if they might be someone who should be evaluated for a bleeding disorder. So these are, available online and can be given to patients to fill out themselves. And if the conclusion at the end says that you should talk to your doctor about being evaluated for a bleeding disorder, then we can do so. Iron deficiency is a very familiar beast in pediatrics and something that we see across the pediatric age range, but it is very common in adolescents with heavy menstrual bleeding. About 50% of adolescents with heavy menstrual bleeding have iron deficiency, and 25% have anemia. Even in the absence of anemia, iron deficiency is associated with significant symptoms, including fatigue, depression, and exercise intolerance. Some patients also describe hair loss or feeling cold all the time, or dizziness or headaches. And some of these symptoms do go away with correction of the iron deficiency. How do we diagnose iron deficiency? Well, ferritin is the most accurate test for diagnosing iron deficiency and the one that we use the most. There are, of course, other lab tests for iron deficiency, but we usually only use them if the ferritin is unreliable, if it's normal and we actually expect the patient does have iron deficiency. The reported ferritin assay thresholds for females are lower than they are for males by a significant amount. And this abstract from Blood in 2022 gathered information about the thresholds that are used in various labs. And the median for males at the lower threshold for males was 27, but for females it was 8, which is a lot lower. And there's growing evidence that these lower reference intervals are inappropriately low. And when I say growing evidence, there's been evidence since at least the 1960s. So in 1967, there was a study where bone marrow biopsies were done on 114 healthy college women from Dallas, and it found that 24% had no stainable iron in their marrow. It is normal in an adult to see stainable iron. So a quarter of these apparently healthy women who had no history of pregnancy, of hemorrhage, of surgery, or any medical conditions had low iron stores. And it's really interesting to read this paper because it's as if the investigators were having trouble even believing this to be true, because a subset of these patients actually got bilateral marrows. So they did the bilateral iliac crests, and a smaller proportion of them, they even took a sample from the sternum just to confirm that this was not somehow a sampling issue. But it was reproducible in all the different locations on those women. And they also had a subset of the women get routine phlebotomy to show that, in fact, they didn't have iron reserve and they would become anemic quite quickly. So deriving a cutoff that is at the lowest 2.5% of the population, which is how we typically derive the lower limit of normal for lab values, is going to dramatically underdiagnose iron deficiency. But this is the way that most of the ferritin reference ranges that you see are still derived and still reported in the computer system. There are randomized trials that show iron supplementation improves symptoms in adolescents with iron deficiency, even without anemia. So this includes improved fatigue scores and improved tests of verbal learning and memory. And this has been, one of these randomized trials was done as long ago as 1996, where they gave oral iron to female adolescents who were not anemic but had ferritins under 12. So they used a cutoff of 12 for that study. And the more recent one used a cutoff of 15. There's evidence that a more physiologic serum ferritin concentration threshold for children should be 20. And this is a 2021 study looking at the relationship of serum ferritin with 2 independent indicators of iron deficient erythropoiesis, the hemoglobin and the soluble transferrin receptor. That study included over 5,000 children from the NHANES database. Now that we have some of this information fresh in our minds, I want to come back to the clinical case from the beginning of my talk. So this was the 14-year-old who has fatigue, more trouble keeping up with her teammates at soccer. She reached menarche at age 12, but says her periods aren't heavy. So there are many questions here about her menstrual history. And we know that she is, in fact, iron deficient, even though it doesn't flag in the computer as a low ferritin. So this patient was appropriately diagnosed with iron deficiency and started on iron supplementation with improvement in her fatigue. Her full menstrual history reveals periods that last 8 days, and she needs to change a super tampon every hour on her heavy days. Her mom's periods were the same, so she didn't think they were abnormal. This is the point where you can start a discussion about options for menstrual suppression if she's interested. And then further testing shows factor VIII activity of 52%, which is not technically low, but she is positive for the factor VIII variant found in her brother. As a side note, so is her mother, also positive for the factor VIII variant, but was told during her pregnancy she could not be a hemophilia carrier because of her factor level being in the normal range. So how many hemophilia carriers are there, and how many are we missing? For every male with hemophilia, there are 2.7 females at risk to be carriers and about 1.5 genetic carriers. And as I mentioned earlier in my talk, about 1/4 of these carriers are expected to be symptomatic with bleeding and have high bleeding scores. If we look at data from the CDC and the hemophilia treatment centers across the country, it's estimated that only 12 to 15% of female carriers who are expected to have bleeding, so not of all female carriers, but just those who are expected to have bleeding, who have access to an HTC, meaning they live within a reasonable distance of an HTC, have been seen at an HTC. So we're missing a lot of them. This number is much higher for males with hemophilia. Of course, they're not all accessing hemophilia treatment centers either, but it's much higher, somewhere around 75%. So we're missing a lot of hemophilia carriers, and should we be picking them up sooner? And this brings the question that really we deal with in pediatrics, which is, should we be testing children for hemophilia carriership? So the guidelines from the National Bleeding Disorder Foundation recommend that all individuals with more than one X chromosome at risk to have inherited a hemophilia-causing genetic change undergo genotyping, but there is no official guidance regarding the timing of testing or what age we should consider this. But I want to show you a quote from a carrier of hemophilia B, and this comes from a paper where they did focused interviews with hemophilia carriers and asked them questions about their care. And she says, "I'm an obligate carrier of hemophilia B. My parents were always very open and honest, and my factor levels were in the 30s, and that really dictated how I lived my life, the care I received, and I can't imagine my parents not knowing that. If an accident had happened and you didn't know, it's actually preventative and proactive to know your medical situation. And then that idea that we're protecting girls by not getting them tested is more harmful." And so there is this idea left over from describing as hemophilia as X-linked recessive, that we should not be testing children because they can't have any manifestation of disease. And of course, this is not the belief of all carriers or all families of female children who are at risk to be carriers. They don't all feel this way. This patient feels very strongly. But as always, shared decision-making is very important in this situation, and it is appropriate to offer testing to hemophilia carriers or to female children at risk to be hemophilia carriers. There are multiple studies that have shown parental preference for earlier carrier testing compared with healthcare providers. Healthcare providers tend to not necessarily offer testing unless there are bleeding symptoms or plan for some sort of surgery or other situation for high bleeding that has high bleeding risk. Some parents say they want genetic testing as early as birth, like we tend to investigate for hemophilia in males who are born and at risk for hemophilia. And at Seattle Children's, it is our standard practice to offer genetic testing and a factor activity level to all females at risk, regardless of age or bleeding symptoms. And I don't take credit for this. This is something that predates me in our hemophilia treatment center here. But it is something that we do, and in my opinion, we do much more thoroughly than some other centers do. When we offer genetic testing, we offer targeted genetic testing, so we know what the genetic variant is in the family, and we do targeted testing for the female child, just looking for that variant. Recently did a retrospective study here at Seattle Children's to see what is the uptake of genetic testing in females at risk to be carriers? We included all females at risk based on family history whose age was less than 18 at the time of a genetic counseling visit with the family from July 2019 through June 2023. We excluded any patients who were obligate carriers because I think this is a different question. We know that they are carriers and they do still get genetic testing, but it doesn't answer the same question. We collected their factor activity levels, whether prior authorization had been initiated for genetic testing, and whether genetic testing was completed. We collected information on which caregiver was present at the visit and any reasons that were cited by caregivers and providers for not pursuing testing. And this was one of the harder things to find because many times it's not very clearly documented. There were 64 children included, and all were siblings of males with hemophilia followed at our center. That's not the only way to be at risk to be a hemophilia carrier. Of course, you could have a mother who is a carrier for hemophilia but doesn't have any sons. We did not find any patient with that description because those patients tend not to make it to us. There were 14 carriers identified, and they had a median factor level of 46%. So as expected from the literature, about half of them had truly low factor levels. Mom was the sole caregiver the majority of the time at those visits. Genetic testing had actually already been done in 27% of patients in 2019, and that seems to me a very high number, and I think related to the fact that we are in very close proximity to the University of Washington, where the site for testing for My Life, Our Future, which is a free genotyping program, and many of the mothers of these patients had been approached for My Life, Our Future and had their daughters already tested. Of those who had not yet had genetic testing, prior authorization was initiated for 49% and only completed for 28%, and factor levels were only drawn for 36%. And these numbers are a lot lower than I expected, since we offer to all, and all have had genetic counseling. And so if we look at why the genetic testing the prior authorization was not even initiated, the most common reason was not knowing the family variant. And so in many circumstances, accessibility of earlier carrier testing depends on an older, often male family member having had genetic testing already. And I think this is an area of improvement for us as well. Genotyping is recommended for all males with hemophilia, and the uptake there clearly is also not that high for reasons, for various different reasons. The second most common reason was the family declined or deferred testing. It was very hard to find their reasons for declining, but there were a couple that we could find. There was one in particular who the family just outright said, like, females can't have hemophilia or bleeding from hemophilia, and couldn't be convinced otherwise. And then there were some who wanted to respect the autonomy of their children to make this decision when they were older. We did also have 3 insurance denials, also showing a lack of understanding among payers of why this genetic testing is indicated. So once we've identified carriers, we can loop them into the HTC comprehensive care system and provide education. And so this is a topic of discussion even at our recent regional meeting about how carriers, including children who are carriers, should receive comprehensive care and how often. So hemophilia treatment centers are federally funded centers across the country. There are more than 140 in the country. We have 3 in Washington state. Our region, which is called the Mountain States region, is the purple one on this map, and you can see covers a huge geographic area and includes Montana and Wyoming, and where there are 2 of the states where there are no HTCs. These centers provide comprehensive care for patients with bleeding disorders and their families. And there was a recent study showing trying to answer the question about how are HTCs doing at taking care of females. And this is a study run by a group who are at the Foundation for Women and Girls with Blood Disorders, and they acquired what are called HTDS reports or data reports for patients cared for at HTCs from 38 HTCs in the country. And you can see at the top of the graph on the right that the proportion of females being cared for at HTCs over time has gone up dramatically in the last 20 years. So I think this is great, and the future is bright. It's now around 40% of patients seen at HTCs are female, whereas even as recent as 2010, it was closer to 25%. So this is a huge win. They also collected information about clinics that are dedicated to females. So these clinics have all kinds of different names, but they're usually joint hematology gynecology clinics or hematology adolescent medicine clinics, where patients are seen at the same time by these two different providers. And most of the HTCs that they receive data from, almost all, in fact, have some kind of a specialized clinic, whether it's once a quarter or once a month, or some places as often as weekly, they have a dedicated clinic. On the bottom graph on the right, it shows the proportion of females, but broken down by diagnosis. And here you can see on that interestingly, the proportion of patients with von Willebrand disease who are female and being seen is declining. I would guess this is because we are recognizing von Willebrand disease in males more often, which is a good thing. But the proportion of females being seen with hemophilia A or hemophilia B, which are the bottom two lines, is essentially unchanged, which could be because they're not coming for care. We're not diagnosing them with hemophilia, and instead using the label of carrier. And so we're not coding them correctly. But either way, that number is still much lower than expected, especially given what we know about how many carriers are out there and how many of them are symptomatic with bleeding. So what can we do? We need to increase education and awareness around how bleeding disorders present in females so that we can recognize this. We need to evaluate females with heavy menstrual bleeding for bleeding disorders and iron deficiency. We need to educate patients and colleagues about iron deficiency and ferritin reference ranges, how they're usually wrong, and also try to change the reference ranges if we can. As a side note, would also help to increase the accessibility of IV iron supplementation, because many of these females with heavy menstrual bleeding and very severe iron deficiency can't correct their iron deficiency with oral iron, and IV iron is surprisingly hard to get. Then detailed family history and outreach to females at risk is needed, particularly for the X-linked bleeding disorders. And sometimes this can take multiple visits with a family and genetic counseling on more than one occasion, because historically they may have been told that females in their family are not at risk. And this really can get entrenched in their understanding of the disease. Last, I'm just going to put up some resources and references. The Foundation for Women and Girls with Blood Disorders is really a great website that has webinars and educational materials. It also has a podcast called 721, which, as that suggests, is just all about periods. It also has information about blood disorders other than bleeding disorders, including female-specific considerations for sickle cell disease and other things. These next two are the self-administered bleeding assessment tools that I mentioned. Better You Know, which is the put up by the National Bleeding Disorder Foundation, formerly National Hemophilia Foundation, and Let's Talk Period, which is the Canadian one, which is also awesome. And then this is a nice link about frequently asked questions about women and girls with bleeding disorders. And then last, I just want to thank all these wonderful people, very dedicated team members who help take care of our patients, including taking care of them in clinic and taking care of their needs for school and mental health, and chasing down their ferritins over and over again, helping get insurance prior authorizations for genetic testing and IV iron supplementation, which is surprisingly hard to get. And then I'm sure I'm missing some people on this list too. But the hematology team is really awesome at helping take care of these patients. The first question that I see on here is regarding ferritin deficiency. Could you speak to the reliability of iron supplements and any other considerations related to the regulation of supplements? So there are a lot of different iron supplements available and over the counter. And the one that we prescribe the most is ferrous sulfate, but a lot of folks don't tolerate that medicine very well because it doesn't taste good, and it can cause nausea. And so a lot of the time, even if we prescribe it, they're not taking it. And there isn't really a lot of regulation around the oral supplements, and it's very common that we see children come in who are taking a supplement that is in fact very low dose. So they have to drink, say, 10 mils of a liquid and they get 5 milligrams of actual elemental iron. So, I think we try, and when we say start taking some iron, to be very specific about what formulation, where are you getting iron, and make sure that you look at the ingredients and look at the actual elemental iron in there. And I think, I have a tendency to offer IV iron very early on. And this is because if even if the reason is, I can't take this iron supplement, it makes me feel sick. And that's because a lot of the time, these patients with heavy menstrual bleeding and iron deficiency are in such iron deficit that they would have to take iron for months and months and months. And it's just the iron deficiency is affecting their quality of life. And if we can get them IV iron supplementation, then we can change that much more quickly. And it is a very safe intervention. I think there's some belief that IV iron is somehow dangerous. We don't need to use it in pediatrics because our patients should just learn how to take the supplements by mouth. But I think we can really end up in a cycle with some of our patients where 6 months, a year, 2 years later, they're still iron deficient because they have ongoing losses and they're just not able to get enough iron through the oral medications.
Thank you. I was permanently muted for a second, but now I'm unmuted. And it looks like Gavin Roach, do you have your hand up? And if so, feel free to unmute and ask your question.
Thank you. Good morning. Yeah, I'm Gavin Roach from Hematology, office mates with Kristen. Kristen, that was excellent. You did talk about ferritin ranges at labs sort of going down to thresholds that we think are truly not normal. And I wonder if you could also discuss the sex-based differences in ferritin ranges and if those are correct or not, and then offer to the audience what you would use as sort of your cutoff for what you think most children or adolescents should have in terms of a ferritin level. I think that's helpful for our colleagues to know when should I think about starting supplementation, even if they're not, frankly, anemic.
Yeah, great question. I think that's a really important question because we see patients referred for iron deficiency often very late because it wasn't recognized when it was mild. And I think the physiologic, the data that we sort of believe in hematology, which really is linked to erythropoiesis, suggests that children and in that study, children were up to age about 15, should have a ferritin of 20 or higher, regardless of sex. And that non-pregnant women, which included down to age 15, so included adolescents, some of the older adolescents, should have a ferritin of 25 or higher. So I usually say like 20 to 25 or higher for most of my patients because the adolescents that we see with heavy menstrual bleeding tend to live right around that 15-ish age. And there is some debate about whether somehow the hormone milieu between males and females, that there's some physiologic reason the ferritin should be lower. And in adults, as you know, there is some literature suggesting that ferritins of 50 or higher should in fact be considered normal, and that anything under 50 is early iron deficiency. I don't really know the evidence for, or I don't think there is good evidence for actual hormone-related differences in ferritin. And if there is, it's slight. It's certainly not this gap between, say, 6 and the 27 or 30 that is the lower limit of normal for males. And in any case, that study looking at hemoglobins and soluble transferrin receptor levels, really using both of those independent predictors in children, regardless of sex, I think that one of them, the analysis landed at 19.9, and for the other variable, it was like 20.0. So they were right on exactly the same. So I think at least for children, which is mostly what we're talking about, and pregnant women and adults, I'm gonna say I think that's a whole other bucket. But for children and adolescents, I think I tend to use 20 or 20 to 25. I see one more question in the chat, which is, what parameters are there for warranting IV iron infusion? Could you justify if not anemic, but just iron deficient? And is IV iron typically fully covered by insurance? It's great questions. So it depends on the insurance, whether it's covered. And yes, I have given and do give IV iron to patients who are iron deficient without anemia, because those studies, so one of those studies was by Sarah O'Brien at Nationwide Children's Hospital, were non-anemic female adolescents with heavy menstrual bleeding, and their fatigue scores improved. So especially if the patient is complaining of symptoms, and fatigue in adolescence, of course, is a very complicated thing. It's caused by many different things. And so you really have to have a discussion about what are all these other things, like your screen time and your lack of sleep and your busy schedule, that could be contributing to your fatigue. But even in that scenario, the fatigue scores in those adolescents did go down. They didn't go to zero, but there were contributors from their iron deficiency, and those are randomized trials, or randomized studies. So I think I do offer it. It is. So I would say, and in that study they used 15, but I would say if there's a patient who has a ferritin that is, solidly under 20, and they're complaining of fatigue, and they would like to try IV iron to see if it alleviates their symptoms, there is evidence to back that up. I think that's something you can offer medically. Whether insurance covers it is a whole is very variable. Some insurances don't require any prior authorization for IV iron, and we just can give it. Some have preferred formulations, and some of these formulations, as you may know, require 4 or 5 separate visits for IVs and infusions, because the dose that can be given in a single infusion is very low. So that the one that we have on formulary here at Children's is iron sucrose, and I have heard people describe giving iron sucrose to assault, because we basically have to bring the patient in weekly for IV iron for 5 weeks, when there are formulations that can give even a higher dose than that in a single infusion. Those newer formulations, like ferric carboxymaltose, are not always approved by insurance. And it's even though this evidence exists, and even though the ferritin reference ranges are all wrong, the insurance companies will often say this patient doesn't have any abnormal labs, right? And we're not going to approve this. And also many of them say they have to have failed one of these cheaper forms of IV iron first. And I think what tends to happen, unfortunately, is when that occurs, and we say, the way we're going to do this is 5 infusions over 5 separate weeks, is that no one wants to do that. They don't want to miss school. They don't want to miss work 5 weeks in a row, to spend a whole day, coming in, getting an IV, and getting an IV is a whole, in and of itself. And so IV iron is typically not fully covered by insurance. Sometimes we can fight the insurance company, but sometimes, because of the systems that are set up and the reference ranges that are perpetuated, we can't get approval. So, we still do use oral iron in those cases. But, as I mentioned, not everyone either can take oral iron or responds to oral iron.
Thank you. We're almost out of time. I think you ended up answering all the questions in the chat, so thank you so much. Thanks, Dr. Meyer, for a wonderful talk. For all of you who are still looking at the screen, please fill out an evaluation for us. You can use the QR code on the screen, or you'll be getting an email later today from our team. And I just want to say thank you, Dr. Meyer, for that really informative talk and for pointing out all the bias that still exists or has existed up till now and trying to dispel that. So we really appreciate all the knowledge we got from you today. And thanks to our audience for sticking with us by WebEx, and we will see you all next week. We'll be online next week as well. Thanks, everybody.